Hello, this is Mike Eisen. Thank you very much for joining today. I'm going to be introducing, I think, the first session. We can move forward. I want to thank all of the other societies that are contributing to this: AOPO, AST, ASTS, CST, ESOT, ISHLT, NATCO, TTS, and UNOS for helping to pull this second meeting together. A special shout out, I think, to Emily Blumberg, who really got the ball rolling on this and has been instrumental in moving the entire process forward. But it really has taken a team of experts from all of the various societies to get the meeting up and running. So we're going to start today with what I think is going to be incredibly exciting, an update on available data and some updates on current registries. I would say before we move into this is that getting data is going to be critically important, and I would encourage all centers to participate in one of the existing registries to put your data in so that we have useful information to provide reports like we'll be doing today. You can go to the TTS website, tts.org, and click on the COVID-19 dashboard, and there's a section on available registries, and you can find one that you might be interested in participating if you're not participating already. I'm going to introduce the first three speakers and then let them proceed with their presentations. First, we'll have David Klassen from UNOS providing an update on impact on the OPTN. We'll then have Massimo Cardillo from the National Transplant Agency in Italy provide us on information on the impact of donation and transplantation in Italy. We'll then turn and get some information from two experts, Olivia Cates from University of Washington, a fellow who's been really pulling together a great multi-center case report registry. And then we'll hear from New York from Marcus Piera, who's the director of Transplant ID at Columbia, to give us some insight about COVID-19 among solid organ transplant patients. After their presentations, we'll start talking a bit on a discussion between the speakers and questions that you may have. So we'll start by turning it over to Dave.
Hi, thank you, Mike. Yeah, this is David Klassen. I'm the Chief Medical Officer at UNOS, and I'm going to give a brief talk on the data that we've accumulated that shows the impact of the COVID-19 pandemic on transplants and donors within the OPTN in the United States. Before I get started, I really would like to acknowledge the dedication of the transplant community as a whole to caring for the patients that we're responsible for and providing access as best we can for transplantation. And also like to acknowledge those of us who work in the face of personal risk. I think that's important to always remember. And additionally, I'd like to echo what Brian Shepard at UNOS has commented on, that communication and cooperation are the hallmarks of our transplant community, and they probably have never been more important than they are today. And so with that, I'm going to, if you could give my first slide, please. Okay, so this slide here shows the number of deceased donor transplants by week that have been occurring in the OPTN. The figure on the left shows by specific organ. The y-axis actually is the time from the beginning of February up until actually the data ends Thursday of last week, April the 9th. And what you can see, the top line, the blue line, is the number of deceased donor kidney transplants done. And you can see it's changed from an average weekly number of about 375 and has dropped down to about 220, which is represents a 40% decrease. Most of that decrease really has been apparent since the beginning of March. The next line, sort of the light green line, represents liver transplants, and they've decreased by about a third. Again, most prominently since the beginning of March. The red line is heart transplantation, which has also decreased by about 40%. And the bottom line is lung transplantation. Although there are fewer lung transplants being done across the country, actually the impact on a percent basis has been the greatest there, and they've decreased by about 60%. We've attempted to look at this geographically across the country, and these are, that's shown on the panels on the right. And we've divided it into some broad geographic areas. These do not represent the typical OPTN regional distributions, but rather, again, broader areas of the country. And you can see, I think, the impact in terms of number of transplants has been very prominent in the Northeast, as we might expect, but also in other parts of the country as well. The North Midwest and the Southeast in particular have shown decreases. In the last week or so, there has been some suggestion in parts of the country that the rate of decline has slowed and in some cases even increased slightly. So this may represent sort of the flattening of our donor transplantation curves, if you will. But again, these data change very quickly, and what we see now may not be the same next week. Could I have the next slide, please? These are living donor transplants across the country, and what you can see is, again, starting in the beginning of March, living donor transplants have decreased very, very dramatically. We now have just a few occurring each week. These have been in the Mid-Atlantic area and a little bit in the southwest parts of the United States. But in most parts of the country, living donor transplantation has stopped completely. The panel on the right shows a number of things: waitlist additions and waitlist inactivations. And what you can see here is on the green line that waitlist additions have declined a bit over the past month, but not as dramatically as transplants overall. The blue bars, though, indicate inactivations based on COVID-19 related issues. And so a large number of programs have been inactivating patients on the wait list. In contrast to deceased donor transplants, these are the actual deceased donors that are recovered, again, by week. And this represents what the OPOs across the country have been able to do. And again, starting on the left, is the total number of deceased donors procured over the United States as a whole. Again, the first data points start at the beginning of March and running up toward the end of last week. And what you can see is that overall, there has been about a third to almost now half, 50% decrease in the number of donors recovered every week. You can see again geographically, there have been changes in the North Midwest and the Southwest. In the last, we monitor this data actually every single day, and we've separated out geographically a little differently in the most recent iteration that's not seen on this slide, but we've separated out the Northeast into the Mid-Atlantic and really essentially New England. And the New England area, which includes New York, has seen a very significant decrease in the number of donors. So this again has continued. Again, the rate of decline in donors has started to abate a little bit, which may signal some stabilization in deceased donor recoveries. But what I would point out is, although we've seen a significant decrease, the number is not zero, and there are still many OPOs. All the OPOs are actually working aggressively and still are able to maintain donor procurements across the country. Can I have the next slide? The last slide then in my brief section is just really to highlight very briefly some of the policy and safety considerations that the OPTN has done. And we're just not going to go into these in great detail, but on a relatively rapid basis, we've changed some policy that has relaxed patient data. We've extended the use of data for determining listing status. We've made some adjustments in terms of wait time continuation and modification of wait time initiation. MPSC monitoring and enforcement criteria will be shifting, and we're looking at the eligible death definition as part of the OPO metrics. We've made a recommendation for the use of local recovery teams for organ procurement. That's not a mandatory policy, but it is a recommendation. And we've also are looking very closely at COVID-19 donor-derived disease transmission reporting. We've seen a modest number of reports of potential disease transmission, but as of yet, there has not been any documented and confirmed COVID-19 disease transmission. So with that, I will stop and turn it back to Mike.
All right, and we'll go straight into the next speaker, Massimo.
Yes, as for Italy, the situation for COVID-19 outbreak is improving in the last week. As the general situation in Italy, we reached about 155,000 infected patients out of 1 million of performed swab in the general population, 20,000 patients deceased and 35,000 recovered. 100,000 are still positive, and 30% of them are hospitalized with the symptoms, and 3% are in intensive care units in intensive treatment. As regards the impact on donation and transplantation activity, since the starting of the outbreak, we have foreseen to perform in all deceased donor to investigate the presence of the virus with a testing on the broncho aspirate that is mandatory for all deceased donor, and the pharyngeal or nasal swab is mandatory for recipient. The impact on organ donation and transplantation is very similar to that observed in the UNOS data. You can see in this slide the weekly trend of organ donation in Italy by week. And as you can see, starting from the 24th of February, we had a slight decrease in the number of referred donors and the utilized donor too. And only in the last week, we observed a slight reprise. As you can see, we had 45 donors referred in the last week, and 21 of them were used. In the next slide, you find the weekly trend in organ transplantation. That is the consequence of the decrease in organ donation. So, as you can see, in the last 6 weeks, we observed about a 40% decrease in transplantation activity, and most of this decrease was in the region of the north of the country. Anyway, as you can see, in the last week, we observed a reprise. We hope that this will be confirmed in the next days. And as regards the last slide, please, Erica, will you please show the last slide? These are data that we are collecting for the COVID-19 positive patient among the transplanted patient and the patient on the waiting list. We are collecting this data by merging two databases, the one general database of all the COVID positive cases in Italy and the database of transplanted patients in the National Transplant Agency that I coordinate. So, as you can see, we found these are preliminary data. Anyway, we found 146 transplanted patients that are COVID-19 positive with a prevalence of 0.36%. That is fourfold compared the overall prevalence in the general population. We are dealing with about 38,000 transplanted patients from 2000 to March 2020. As you can see, these positive patients are in 17 cases heart, 21 liver, 2 pancreas, 8 lung, 103 kidney. we investigate the prevalence of COVID-19 positive patient among the patients on the waiting list for organ transplantation. We found the 73 positive patients. That means out of 8,000 patients on the waiting list, that means about a prevalence of about 0.86%. That is about double compared with the prevalence among the transplanted patients, and this is also important data to show and to understand. Thank you very much for your attention for this opportunity.
Thank you. And we'll move on to Olivia's talk.
Thank you. I'm Olivia Cates. I'm a second-year infectious disease fellow at the University of Washington. And with the support of my mentors, Dr. Cindy Fisher, Bob Rakita, Erica Leese, and Ajit Lemay, I'm leading our multi-site case report registry project. Next slide, please. So we've developed what I hope is a user-friendly electronic case report form, and all the data requested are de-identified and IRB exempt, allowing for speedy enrollment. But the most important feature of our project has been the guiding principle of open collaboration. This really would not be possible without our contributors, now more than 50 clinicians around the world, whose hard work and goodwill have been truly incredible. One way that we hope to repay their generosity, or at least pay it forward, is by regularly sharing insights from our project, even as it's still in development. Next slide, please. When I prepared these slides on Friday, we had 120 cases reported to the registry. The median age of patients is 56. Although the youngest patient is 3 years old, fewer than 10 pediatric cases are included so far. Patient demographics roughly align with the demographics of transplant recipients in the United States, where most of these cases have been reported. The vast majority of patients have at least one comorbidity, and most have two or more, with hypertension, diabetes, chronic kidney disease, and coronary artery disease most common. Patients in the registry are recipients of 82 kidney transplants, 21 liver transplants, 15 heart transplants, and 10 lung transplants, and some patients have received more than one transplant. The median time post-transplant is 5 years, and currently there are 16 reports of patients who were transplanted in 2020. The majority of patients are on maintenance immunosuppression with tacrolimus, often in combination with prednisone and mycophenolate. 10% are on cyclosporin, and 10% are on mTOR inhibitors. 16% of patients have recently received induction or intensified immunosuppression. When patients present, 50% have fever. Most patients have lower respiratory tract symptoms, 30% have upper respiratory tract symptoms, and 30% have gastrointestinal symptoms. For the approximately 15% of patients who are presenting without cough or dyspnea, the symptoms that prompted testing have been isolated fever, diarrhea, or myalgia. A very small number of patients have been asymptomatic and identified by screening tests. Next slide, please. 30% of these patients have been managed in the outpatient setting, 70% have been hospitalized, and 49% of all patients have been admitted to an intensive care unit. 19% of all patients have been intubated. 20% of patients had suspected concurrent infections, the majority of which were bacterial. 60% received some experimental treatment for SARS-CoV-2, with almost half of all patients treated with hydroxychloroquine. Although there's been discussion of a possible protective effect of immunosuppression or even an antiviral effect of mycophenolate, 70% of patients had their immunosuppression reduced, and in most cases this meant reducing or holding mycophenolate. I've been asked whether we see a difference in outcomes based on organ transplanted, and looking at our preliminary data, I observe higher rates of hospitalization and intubation among lung transplant recipients. I've been asked whether more recently transplanted patients present or progress differently, but so far I've not observed a difference among the 16 recently transplanted patients. I've been asked whether outcomes vary based on the maintenance immunosuppression regimen, specifically for patients on sirolimus, but have not observed a difference among the 13 patients receiving that drug. And I've been asked about mortality. While follow-up is not completed, so far 11% of patients have passed away. Our study will ultimately address all of these questions and more, but today I have to emphasize that these data are preliminary. They've not been examined for confounders and no formal statistical analyses have been performed. The initial case report form does not require a fixed follow-up duration, but beginning today, contributors will be invited to fill out 28-day follow-up forms with updates to clinical course, management, complications, and outcomes, all standardized to the 28-day follow-up period. It's our hope that the result of this project will be a richly detailed and high-quality contribution to the body of literature addressing COVID-19 and transplant recipients. I personally welcome your questions and comments, and I'm making every effort to be available by email. Once again, thank you to my local mentors, to all of our contributors and their teams, many of whom are listening and even speaking today. And I'd also like to extend my best wishes to colleagues at Columbia University, my previous institution, including past teachers Dr. Pereira and Dr. Hussein. Thank you.
Thank you, Olivia. We'll move on to the center of the epidemic in New York, and Marcus will update us on the experience at New York Presbyterian.
Thank you, Mike, and thank you, Olivia, for the best wishes. And thank you for the invitation to present some of our data on what we've experienced so far here in New York City. As you mentioned, we're in a hyper-endemic setting at this point. So the data that I will be including here is for New York Presbyterian. So this was not a misspelling, NYP. It comprises of two large institutions, Columbia and Cornell Medical Centers. Next slide, please. So as of last Friday, when I put these slides together, we had 122 patients, solid organ transplant recipients who were diagnosed with COVID-19. The number as of today is up to 151, just highlighting how dynamic and ongoing this infection is here in New York City. We have been able so far to analyze 90 patients as of April 3rd. And for the purposes of the data that I will be presenting, we classified these patients by disease severity. And to keep it simple, all the outpatient management or those who remain outpatient were the mild severity. Those who required admission to the general medical floor were the moderate disease patients. And then severe disease were those who required mechanical ventilation or an admission to the intensive care unit, or who ultimately passed away from COVID-19. Slide, please. So the next following slides will be data rich with a number of tables. So in the first red rectangle that's going to come up, we looked at age. As you know, it's a significant risk factor in the general population. And we actually found that in our cohort, it was also quite significant, in particular in those over 60 years of age, were far more likely to have severe disease than otherwise. Gender, on the other hand, did not seem to contribute too much to disease severity, at least in this small cohort. And just to piggyback on Olivia's initial question as well about different types of organ transplants, we have not seen a predilection for disease severity among any of the transplants, but you can see the breakdown here. By far, we had kidney transplants being affected by COVID-19. That's generally due to it being a large transplant center for kidneys, but the lung transplants were the second most affected. And but they were not more likely to have severe disease, at least as of now. Again, another important question was the time from transplant to development of COVID-19 and whether that would be a risk factor for disease severity. As you can see here, and this is actually in the next rectangle, it did not seem to correlate. Most of our patients were many years out from transplant, but we also looked at the subset of those within a month of transplant, of which we had 3 so far, and as well as those within the last year, and this did not seem to correlate with disease severity. We also looked at the comorbidities of these patients, and this is not all inclusive. I had to take some of the risk factors or comorbidities out of here. But in the next slide, in the next rectangle, you will see that hypertension did seem to correlate, just like in the general population, with disease severity. And then in the next rectangle, also active cancer. We had 3 patients who were concurrently being treated with chemotherapy, and those 3 have not done so well. We looked at CKD, diabetes, chronic lung disease. We actually had 1 patient with HIV who had kidney transplant, and those did not seem to correlate with disease severity. And then this is the next box is our baseline immunosuppressive regimens for all of those patients. And you can see, you can go back to the last slide. Baseline immunosuppression did not seem to correlate either with disease severity. And again, many of our patients were on mycophenolate. So to raise that issue, whether that is a potent antiviral or not, it didn't seem to be the case here. Next slide. So about 70 6% of our patients in this entire cohort were ultimately hospitalized. And the next two slides are about those hospitalized patients only, for which we had a little bit more data. So in terms of the vitals, which is the first red rectangle, the significant vital signs upon presentation were the tachypnea and hypoxia. And you can see here they were strongly correlated with disease severity, in particular the hypoxia. And then we were able to report on a number of initial lab results, blood counts, chemistries, and other inflammatory markers, which are included in the bottom of this table. And white blood cell count do not seem to correlate. And we also looked at the neutrophil to lymphocyte ratio, something that had been discussed, which is the NLR over there in the table, as potentially predictive of disease severity. And although those numbers, 5.27, is a high ratio in general, it didn't seem to be differentiated between disease severities. Albumin, interestingly, did seem to correlate. So for those who had in general a median lower albumin, seem to have more disease severity, and whether that is representative of additional underlying comorbidities or frailty or different issues that seem to be correlated. Hepatitis did not seem to be significant in this cohort, neither did creatinine levels, which were at baseline elevated for many of our patients. And then, as many centers are curious about the inflammatory markers and whether those can be predictive, I know there's a lot of literature out there for the general population. These are the initial lab results for our population, including procalcitonin, C-reactive protein, D-dimer, ferritin, and IL-6 levels. As many of you know, we were looking into blocking IL-6 receptor blockers and whether that correlates with severity of disease. So by and large, the only significant initial lab that was perhaps predictive of severity was procalcitonin. Whether that is something significant or whether it is related to superimposed bacterial infections, we were not sure. We have not found many patients with bacterial infections in this cohort, at least, so we're not sure exactly the significance of procalcitonin. But mind you, if you look at C-reactive protein, D-dimer, ferritin, and even IL-6 levels, those are elevated in basically the entire cohort, but not particularly predictive. Next slide. And then the last table are our treatment management, both for immunosuppression as well as antiviral therapies. So in the first red rectangle, we looked basically upon meeting MS and infectious diseases. It was agreed upon that in terms of changes in immunosuppression, that we would go first with decreasing or holding antimetabolites, despite some of that literature about, again, mycophenolate having antiviral properties. And again, it seems difficult to make any conclusions by this, but most of our patients had antimetabolites decreased or held, and it didn't seem to correlate with disease severity or progression of disease. The next red rectangle highlights our antiviral therapies. So we decided on hydroxychloroquine for most hospitalized patients who had significant risk factors, and immunosuppression was included in that category. So as you can see, 92% of our patients receive hydroxychloroquine during their hospitalizations. Columbia, as opposed to Cornell, did include azithromycin initially in our protocol. So you can see that 44 of those patients did receive concurrent azithromycin. We later dropped that as part of our recommendation, so you can see that some of the numbers dropped off later. We were able to enroll a few patients on remdesivir only. There was initially a lot of trouble enrolling them due to drug supply, but we certainly have picked up lately. And then the next rectangle highlights our immunomodulatory therapies, including bolus steroids for patients who were believed to be either in this sort of cytokine storm state or require some increased anti-inflammatory therapies, as well as tocilizumab, our anti-IL-6 receptor blocker. So 8 patients received that, and you can see that most of those patients were already in the severe disease state. And then the next rectangle shows the breakdown in terms of the highest level respiratory support for those patients. So most of the moderate patients require either room air nasal cannula, but some did require non-rebreather masks. And the vast majority of our patients in the severe disease category ultimately were intubated and required mechanical ventilation and ICU admission. We did have 3 patients who chose not to be intubated, did not want to proceed to ICU, so they went more in the route of palliative care and passed away before any of those interventions. And we included them in the severe category because they would have been intubated otherwise. And then in the next slide, ultimate outcomes. So 19 of our patients ultimately went to the ICU. That's 30% of the hospitalized cohort. 10 patients ultimately passed away. That's 15% of our hospitalized cohort. And the good news is that 18 of those patients, or about almost 30%, have been discharged as of April 3rd. Next slide. So some concluding remarks. It's obviously too early to tell, and we don't necessarily have good measures for comparison, but it seems that COVID-19 seems to have a high level of morbidity and mortality in our transplant population so far here in New York. 11% of the entire cohort died, 15% of those hospitalized, and 37% of those who went to the ICU have passed away already. Obviously, we don't have a reliable denominator because there was severely limited testing abilities for all of our patients. And despite aggressive reaching out to our patients and trying to test them, we really don't have a denominator. So we don't know what these numbers really mean so far. As many of you have concluded in your centers, hydroxychloroquine is of uncertain efficacy, in particular for those patients with more severe disease or have been in a hospital for a long time. Obviously, we haven't had the ability to analyze that data so much yet. But then some solid organ transplant specific considerations. We obviously need to better understand what is the optimal immunosuppressive management. Is it really reducing or holding mycophenolate or additional strategies? The same with immunomodulators. These patients are already immunosuppressed, but certainly what does it mean to add additional therapies like IL-6 receptor blockers? We had 8 patients who received tocilizumab. Many of them, unfortunately, had received it late in the stage, had already been intubated for a day or two, and we did not see necessarily great results from that. And then there was some concern, as many of you know, about false negative results of the initial PCR nasopharyngeal swab. We had 7 patients who initially were negative on the PCR, but due to high suspicion of symptoms, were retested 1 to several days later and ultimately became positive. So this is an important consideration as well, as we rely on that test for most of our management. And then last, just as David Kleisen was talking about, donor-derived infections. We don't know for sure, but we do have a case of a living donor liver transplant where the donor and the recipient, as well as several surgical staff, were ultimately found to be positive with 4 days after that transplant. Again, this is probably reflective of an area that's hyper-endemic, and we don't know necessarily if there was direct transmission or not, but certainly is an important consideration as you're deciding whether to proceed with living donor transplants or even deceased donor transplants in your own regions. And I think that's the end of my slides. Thank you.
Perfect. So thank you all for giving these presentations. I think they really raise a number of questions. I have one question first to Dr. Claassen. Is UNOS collecting data on donor screening for COVID-19?
I'm sorry, could you say that? Collecting data on what?
Donor screening for COVID-19 SARS-CoV-2?
We are in the process of getting the data elements to do that. It isn't quite yet, but it should be shortly. So we're trying to define exactly how that data should be collected and what data elements it should encompass. But the answer is yes, we will be doing that very soon.
Perfect. And then I thought it was kind of interesting that the mortality rate from the multi-site registry and the group at New York is about the same overall, 11%. I was wondering, Olivia, since about half of the patients have gotten hydroxychloroquine, have you looked at all to see if there's differences in outcomes in those patients that received hydroxychloroquine versus those that hadn't?
At this point, I haven't been able to look at differences in outcomes based on treatment, and I wanted to defer doing that until we had a more standardized length of follow-up. I actually imagine a larger proportion of patients may be being treated after their initial reports are entered into the registry.
Gotcha. And then, Marcus, any safety data since almost all your patients got hydroxychloroquine?
Yeah, so far no major adverse events. We've been monitoring for, in particular, QTc prolongation, and we have not seen that. And as you can imagine, we were also worried when we added azithromycin to that combination. We have also not seen that.
Perfect. And then, is there a specific test that you're using that may be giving higher false negatives, or you think it's sampling?
That's a good question. We're using in-house PCR tests through I believe it's a Roche platform. I think as we know there are some concerns about just the nasopharyngeal swab technique itself, right? We're largely operator dependent, and you can imagine in the emergency room or on the floors, whoever performs those tests perhaps might be using different techniques. But I believe that it's not necessarily, I don't think it will be the platform per se.
And then one last question for Massimo. Do you have any sense on what the mortality rate is on the 146 patients, transplant patients with COVID-19?
Yes, we are collecting this data, but unfortunately, it is not available at the moment. So I am not able to give this data at present.
Okay. Well, to keep us on time, I'm going to turn it over to Emily to take us in through the next section.
And I want to thank you, Mike, and I want to thank all of our speakers for the next section. For the next section, we really wanted to focus on some key management issues, specifically as they pertain to different organs. So we'll be hearing first from Dr. Ali Hussein from Columbia Presbyterian to talk about renal implications. This talk will then be followed by Dr. Marta Ferrero from the hospital clinic in Barcelona, Spain, where she will be focusing on ICU and pulmonary considerations. This talk will then be followed by Dr. Enrico Ammirati, who will be talking about cardiac complications, and he's from Niguarda Hospital in Milano, Italy. Following that, Dr. Saima Aslan from the University of California in San Diego will be talking about therapeutics for COVID-19. And to end on a more optimistic note, we'll be hearing from Dr. Sejal Tanna from Northwestern University talking about safe discharges and home management. So we'll start off now with Dr. Ali Hussein.
Thanks very much. You can go to the next slide. Thanks. So obviously the interest in the renal implications of SARS-CoV-2 has been increasing ever since it was recognized that the receptor was ACE2, which is obviously, as you all know, present not only in the lung epithelial cells, but also in kidney epithelial cells. Early reports from cohorts around the world have had pretty varying incidences of AKI reported, anywhere from 0.5% to 29%. We think this is probably based on a few things, like the severity of illness of people in the cohort, who's getting tested, and what they're defining as AKI. Overall, it seems like probably around 5% of hospitalized patients develop AKI, but 50% of those who end up in the ICU do. We've had a similar experience in Colombia. About 50% of ICU patients will get AKI, and about 30% will require renal replacement therapy. The mechanism of this AKI is not yet clear, but some autopsy studies that have recently come out have been helping us figure it out. So if you look at the top right corner of the slide, that's autopsy data from 6 patients in China who died of COVID-19. And in these 6 patients, the predominant kidney histologic findings were severe ATN, prominent lymphocyte infiltration, as you can see, infiltration with macrophages. But in addition, on the right, that's C5b9 staining. So there's obviously also complement activation. And then they also found viral antigens in tubular epithelial cells, as well as all these inflammatory findings. In a separate Chinese series, which is in the bottom right corner of the slide, is a autopsy series from China that had 26 patients who died of COVID-19, 9 of whom had AKI. And in these 26 patients, again, there was a lot of ATN, as well as even frank necrosis in some cases. In addition, they also saw these coronavirus particles in the tubular epithelium and photocytes. And then on the the bottom left image, you can see they had stained for the SARS-CoV nucleoprotein, which they found in the tubules. And then on the bottom right, they had noted an upregulation of ACE2 in the renal tubules as well. So it seems like there's a multiple mechanism for AKI, including both direct virulence of the SARS-CoV-2 virus, ATN, probably from critical illness, perhaps things like systemic hypoxia, rhabdo, they're all contributing. From our standpoint in particular, it's been important because AKI has carried a very poor prognosis, and that's kind of been borne out across multiple studies. So this slide actually is already out of date, but we tried to pull together the data from several sources to see if we could capture what's been discovered so far about the prognosis associated with AKI and COVID-19, and found a pooled odds ratio of death of about 24. So obviously it portends a very poor prognosis, and we found that to be true in our kidney transplant recipients as well. So about a third of all of our kidney transplant recipients who've been admitted with COVID-19 have had AKI. That's similar to numbers from the group from Brescia, Italy, which just published a case series in KI, which 30% of patients did. And virtually all of our kidney transplant recipients who have ended up in ICU have had AKI. So it's been a huge complicating factor in their management, especially as it's increased our burden of providing renal replacement therapy in what's becoming an increasingly resource-limited setting. So for those of you who have not hit your peak yet, be prepared to really expand your ability to provide conventional hemodialysis and continuous renal replacement therapy in terms of increasing your access to staff who are qualified to do that, as well as supplies like solutions and machines. Next slide, please. But at the same time as we're talking about COVID-19 causing kidney dysfunction, it's also important to recognize that CKD clearly emerges as a risk factor for severe disease. And this is really relevant to us in transplant in particular, given the really high proportion of transplant recipients who have CKD. I think numbers show that 5 years after a solid organ transplant, about a quarter of people have CKD. So clearly something that makes our patients in particular a high group for complications of this infection. Again, there's been really variable reports from previously published cohorts of what proportion of COVID-19 in patients will have CKD. But really, even though I'm showing you a number here of 1 to 57%, that 57% was really an outlier. And most cohorts have reported a prevalence of around 1 to 6%, averaging around 3% of patients who are admitted for COVID-19 having chronic kidney disease. However, uniformly, everyone's reported worse outcomes in this subgroup. And again, when we pooled the data that's available so far, the odds ratio for death for patients with CKD was 3.5. And again, many of these patients will end up in the ICU, even those who don't die. And I think once we close out a lot more cases, we'll see the death rate in this subgroup is probably even higher than been reported so far. Again, the reason for this all is not totally clear yet. Of course, patients who have advanced kidney disease have some relative immunosuppression that might make them more susceptible. In addition, there's a really high prevalence of comorbidities in these patients. So in New York, for example, in patients with ESRD, half are 65 or older, 2/3 of diabetes, half have CAD, half have heart failure. And these are all things that we know are associated with more severe COVID-19 presentations. But specifically, our transplant recipients we know are a particularly vulnerable group of patients with CKD. And I won't repeat all of this data because I know Marcus just went over it. But at our center, we've had, and at this point, more than 70 kidney transplant recipients who've had COVID-19. And even though their presentations have been similar to the general populations, you can see there on the right, their outcomes with a pretty conservative immunosuppression reduction strategy has still resulted in 40% developing an acute kidney injury, 27% requiring intubation. And although half have been discharged, among the other half, there's so many outstanding open cases, it's still too early for us to talk about case fatality. So I'd say we still have a lot to learn about this topic as well. Next slide, please. So and I'd say in summary, in reality, we just have a lot to figure out still. So we don't totally know the mechanism of kidney injury, like I mentioned. And one reason this is going to be important for us is if it's primarily an inflammatory response, an immune response in the kidney, and, what the implication of this will be for kidney allograft rejection is something we still have to figure out. We have had our first case at our institution of someone who's had COVID-19 and concurrent rejection. Of course, the management of those patients is extremely complicated. Until we know more about that as well, we won't really get a good sense of what the recovery prognosis or the timeline for recovery will be. And so on the right there, you can see we looked at all of our first 15 patients who were admitted with COVID-19 and tried to see if we could match up their inflammatory markers in terms of CRP with both their outcomes or whether or not they developed AKI. And we were surprised to find that the patients who had the highest inflammatory markers both had resolving AKI, but at the time their inflammatory markers were very high, whereas 2 of the patients who went home who had AKI, those bottom 2 black boxes, both had ongoing AKI despite the fact their inflammatory markers had come down way lower than they were at time of admission. So clearly a lot not known. And then finally, like I said, the management of RRT and especially the management of fluid balance in the absence of readily available RRT is something that will continue to complicate our management of these patients. Thank you.
I'm Marta Ferrero, and I used to be a heart transplant cardiologist, but I've been recently converted to a COVID intensivist. So I'm going to talk to you a bit from my experience in the last weeks in the ICU with pulmonary complications. Next slide, please. Regarding pulmonary complications, we need to be aware that most of the patients present mild symptoms and do not require ICU or respiratory support. But amongst those with pulmonary complications, the need of ICU and respiratory support can be high. Looking at this report describing 1,000 COVID patients cohort from China, we can see that the pneumonia is present in up to 90% of the patients and develops 3 to 5 days after symptom onset. 40% of the patients required oxygen and 6% mechanical ventilation, most of them non-invasive. 5% of the patients needed ICU admission and just a few received ECMO support. When we think of a patient with COVID infection and pulmonary complications, we need to acknowledge that we are facing a new disease and that no evidence-based guidelines exist. So we need guidance from daily experience and we have to learn from the patient every day. I will give you my impressions based on observation and lots of discussion with colleagues. In the table, you can see the highlights of our initial protocol. In COVID pneumonia, we need to be permissive with oxygenation, since hypoxia is very well tolerated in the so-called happy hypoxia or silent hypoxia period. And we want to avoid oxygen damage to the lungs. We will start oxygening patients with saturations around 90% in room air, targeting to increase it to 91 or 92%. When we assess for the need of mechanical ventilation, we need to distinguish between hypoxemia and respiratory failure. 3 parameters need to be taken into account. First, saturation and oxygen requirements. Second, breathing situation, tachypnea, use of respiratory muscles, dyspnea, fatigue. And third, neurological status. We see a high prevalence of delirium and uncertain mental states in these patients that can be relevant at the time of defining invasive versus non-invasive ventilation. Initially, a strategy of early intubation and minimization of a non-invasive approach was suggested. Now we are less aggressive with that, since we have seen many patients do well after some days with high flow nasal cannula or CPAP, EPAP, the first being preferred for its less likelihood of aerosolization and better tolerance. And we may be avoiding the 50 to 80% mortality rate that has been reported on intubated patients. Also, we need to acknowledge the lack of resources such as ventilators in some circumstances. So non-invasive ventilation can play an important role, both looking at the patient and at the environment parameters. On the other side, we need to be in armed surveillance, since we don't want to rush into a crash intubation, increasing the risk for the patient and the security of the team. If the patient is on mechanical ventilation, we need to look at the lung compliance. In early stages, they may be compliant, so we may use low PEEP and higher oxygen, always targeting at the low PO2 side. In more advanced stages, we can see less compliance as organizing pneumonia and fibrosis appear. Then lessons from respiratory distress syndrome can be applied, and we may use protective ventilation with higher PEEP and lower volumes. Recruitment maneuvers can help optimize ventilator settings and define the best PEEP. Of notice, we have seen surprisingly good results with pronation, even in non-ventilated patients. So we would recommend trying it in both scenarios, as the effect on oxygenation is immediate, although it may not be sustained when we achieve the supine position again. PV ECMO should be considered with caution in selected patients and depending on the center resources. We have had a 50% survival after PV ECMO explant so far. But we need to acknowledge that there's a whole spectrum of pulmonary complications in COVID patients that go far beyond the initial pneumonia that you can see on the picture in the left. We can distinguish the viremic phase and the inflammatory phase, probably followed by a third chronic phase where organizing pneumonia and fibrosis arise. Some reports suggested that the inflammatory phase could be less intense in transplanted patients, accounting for not so bad outcomes as expected in our population. The truth on this will need to be cleared out in the future with ongoing registries. As a sample, the two pictures in the middle belong to one of my heart transplant patients currently in the ICU. As seen in the CT scan, there are important areas of delayed organizing pneumonia and fibrosis with no inflammatory markers in blood tests. Of notice, the patient was never intubated despite the severity of the lesions that you see and is doing well on high flows. On the top right, you can see a CT scan image of a massive bilateral pneumothorax on a patient after recruiting maneuvers. He was on VD-ECMO at the time and surprisingly could also cope hemodynamically. On the bottom right, you can find a complex case. There's peripheral organizing pneumonia with a big right artery pulmonary thrombus. In fact, lung embolisms are frequent in this population and need to be ruled out, especially in patients with high TTMR or inflammation parameters, as well as disproportionate oxygenation difficulties. At the same time, we can't recommend full anticoagulation for our patients since we have also seen some life-threatening bleeding episodes. Notice the pulmonary hematoma in the same patients can. Of course, other infectious complications such as bacterial and fungal pneumonia need to be ruled out if fever or infiltrates reappear.
Thank you. Dr. Ammirati.
Hello, that's Enrico Ammirati from Milano, Niguarda Hospital. It's a pleasure to be part of this conference. Cardiac injury is a recognized marker of prognosis in COVID-19 patients, and the rate of cardiac injury defined as an increase in troponin level is estimated between 7.7 to 27.8% of COVID-19 patients, and the mortality in COVID-19 patients with cardiac injury is estimated between 22% to 51%. Cardiac injury, especially in critically ill COVID-19 patients, is reported in a submitted paper from China to 38% of cases, in 38% of cases. If you look at the bottom left panel, you see the proportion of cases with cardiac injury defined as an increase of troponin from admission to up to 2 weeks, more than 2 weeks of follow-up in the hospital. And you can see how non-critically ill patients have almost no cardiac injury, while patients that develop, that become critically ill, they have an increased prevalence of cardiac injury. And if you look at patients that are critically ill but that they survive, you see that the proportion of cardiac injury reduce after about 3 days after admission, while in patients that where cardiac injury persists after 3 to 4 days of admission, the outcome is poor. So they are mainly the patients that are critically ill, non-survivors. And the critically ill definition is based on need for admission in the intensive care unit or mechanical ventilation or shock. And if you look at the level of troponin, again, you see that it's clearly almost since the beginning from on admission that patients with higher level of troponin are at increased risk. So even if in this setting it's very difficult to perform echocardiogram or even ECG, this marker that is very important and is in relation with the prognosis. Next slide, please. And we do not generally perform ECG or echocardiogram on admission, and acute myocarditis can be a clinical manifestation of COVID-19. And at least based on the cases that we manage, or based on the literature, there are just a few. Often these patients present with just chest pain and mild respiratory symptoms. And there are 2 cases where we have the endomyocardial biopsy, and there is no evidence of SARS coronavirus 2 direct cardiac injury. Just in 1 case with ultrasound with electronic microscopy, they found the coronavirus just in 1 macrophage, interstitial macrophage in the heart, but not in the cardiomyocytes. There is no evidence of inflammatory infiltrate as expected in classical myocarditis, even if this picture, for instance, from a patient from Brescia, that is published in JAMA Cardiology, you can see these are here, so they represent edema. There is an intense edema diffuse in the whole myocardium, and it's also found in another case where they perform endomyocardial biopsy, but they did not find inflammatory infiltrates. So a potential explanation is the cardiac injury can be related to a non-specific cytokine-mediated cardiotoxicity. That is something also described for CAR T-cell therapy. This is an example of Takotsubo syndrome as a complication of a critically ill COVID-19 patient. And it's she's a 76 woman admitted in ICU due to severe pneumonia with a respiratory insufficiency that needed intubation the first day. At admission, there was a slight increase in troponin, high sensitivity troponin 19, and you can see the ECG on top C with letter C. And after 16 days, when the patient was extubated, she developed an Takotsubo with typical apical ballooning. I was not able to upload the videos, but it's clear that there are no R waves from V1 to V4 on ECG, and troponin rise to 176. And after some days, you can see that when the patient was finally extubated, that the left ventricle ejection fraction increased, and there was a recovery of R wave with normalization of troponin. So it's important to remind that also Takotsubo can be an important cardiac manifestation in these patients. Thank you.
Thanks very much. We'll now move on to Dr. Aslan.
Okay, thank you. Thank you, Emily, as well as the planning committee for inviting me to participate. Can you go next? So in terms of therapeutics, there are almost 400 clinical trials currently registered on clinicaltrials.gov. Unfortunately, most of these are ongoing. So in terms of current published data, it's mostly anecdotal and mostly case series. There are only a few trials that have been published. There are a variety of drugs that are undergoing evaluation for treatment of COVID-19. And what I show here is just a small subset of current drugs being investigated. Next. What I'd like to do is focus on literature that's been newly available within the past week. Next. So this is a clinical trial that was, or not a clinical trial, but a case series. 53 patients that was just published in New England on Friday. Of note, the data is from the manufacturer, so it's Gilead data, and they basically give us an overview of compassionate use of remdesivir for patients. So in terms of patients that were included in this compassionate use protocol were patients that had COVID-19 and were hypoxic, but did not have any evidence of multisystem organ failure. So patients did not have, creatinine clearance was more than 30, liver enzymes were usually within normal, and no vasopressors. Patients received remdesivir for 10 days, and the endpoint was noted at day 28. This endpoint consisted of looking at live discharge, as well as a 2-point reduction in the ordinal scale, and I'll go over that scale in a minute. So I think what's most interesting to note is of these 53 patients, only a subset of 34 were on invasive ventilation, and the rest were non-invasive. Median duration of illness at the time that remdesivir was started was 12 days. Next. So this is our main data result table. On the top, on the x-axis is the number is where patients were at baseline. So you can see 34 were on required invasive ventilation, and the rest were non-invasive low-flow oxygen. On the left hand, which is the y-axis, is basically where patients were after the end of treatment in terms of oxygen support. And so they basically developed an ordinal scale in terms of 1 being the best outcome and patients were live discharged, and death number 6 being the worst outcome. So based on this, they try to show that about overall 50% of patients in the invasive group got better. And people with mild and moderate disease, a great percent also improved. Their overall mortality in the study was 13%. And again, I think this is lower compared to other published data from critically ill patients. But I think what's important to keep in mind is that these patients were very carefully selected and again did not have multisystem organ failure or need for vasopressors. So my take home from this is that it basically showed remdesivir was safe to use in terms of serious adverse events, but in terms of efficacy, they have ongoing clinical trials, which I think will be much more helpful. And one of those ongoing trials compares remdesivir to placebo for moderate disease. The other interesting drug that a lot of people are in IL-6 inhibitors, in particular tocilizumab. So what I show here is a single center experience. It's basically a case series of 15 patients in China. Of these 15, 7 patients were critically ill. And when they received a one-time dose of tocilizumab, 4 of the 7 survived. And all patients had elevated IL-6 levels, which were then reduced post-dosing of tocilizumab. Next. So sort of caveats to this, and this is true for several studies that I go over, their follow-up is just 1 week. There are no clinical details in terms of what constituted critically ill patients, and there's no comparator group. Next. The next group is also a case series of 20 patients, again from China. These are 20 patients with severe critical COVID-19, again not well described, and all received a one-time dose of tocilizumab. The key point here for me was the discharge home. So 19 of these 20 patients were actually discharged home after average of almost 2 weeks. And they noted that CT scan lesions showed almost resolution in the majority, but it's unclear in terms of what that time period was. And next, there are certain caveats here. One more. The additional caveats with this study, similar to the before one, is that there's no duration of follow-up, there's no details of what constituted severe critical disease, and no comparator. Next. This is a trial also that was just recently put up as a preprint. This is from China. This is a trial looking at the use of hydroxychloroquine in a blinded fashion. For inclusion, patients had to be positive via PCR for COVID-19, and they had to have chest CT evidence of pneumonia. However, patients were not hypoxic, so I think that's important to keep in mind. In my mind, that's mild disease. They excluded patients with critical illness, as well as a variety of other indications listed here. They had 62 patients with 1-to-1 randomization, but no sample size or power calculation. And 31 patients received hydroxychloroquine at a dose of 200 milligrams twice a day for 5 days, compared to their standard of care, which is listed here. So oxygen, unknown antiviral, unknown antibiotic, and immunoglobulin. Next. Of note for control patients, they had a day longer in terms of fever and cough compared to the hydroxychloroquine arm. Next. And this is sort of their main results table. And the red box is sort of the main gist of it, basically showing that patients that were in the control arm, about 55% had improvement. Patients that were in the hydroxychloroquine arm, about 80% had improvement. Next. The details or the issues with this study, again, there were no virological endpoints. An improvement here basically meant day 6. So patients received 5 days of Plaquenil, and day 6 is when they assessed if patients had improved or not. And again, there was unclear duration of illness at the time of enrollment. So what I presented basically are just early literature from the past 1 week. As you can see, there are a variety of methodological issues, which makes it really difficult to see if any of these drugs actually led to a therapeutic effect. And so I think what we really need are proper trials with clinically meaningful endpoints. That's about it. Thank you.
Thanks very much. And we'll be completing this section with Dr. Tana.
Thank you, Emily. Thank you to the committee for inviting me to share our experience. Next slide. So we at Northwestern have developed a uniform checklist to help facilitate safe discharges. This requires a multidisciplinary approach with a heavy social work involvement. Northwestern is in the heart of downtown Chicago, so some of the common issues that come up are trying to find alternatives to mass transit, ride shares, and unsuitable living situations. Upon discharge, all of our patients are given one surgical mask. They're also given uniform instructions at discharge in our EMR regarding duration of self-isolation per the current CDC guidelines. If the patient has a positive COVID-19 test or it's pending at discharge, they're automatically enrolled in our monitoring program. This involves a daily MyChart questionnaire. This is followed up by a phone call if they report any concerning symptoms or don't respond to the MyChart. If they have severe symptoms, they are instructed to return to the emergency room with a proper handoff. Next slide. We've also embedded an extra layer monitoring for our transplant recipients. So for our solid organ transplant recipients that are COVID positive, they're enrolled in our transplant watch list. This involves a daily call from the transplant team. Since we don't have the ability to retest right now, we are extending their COVID infection flag in the EMR for 40 days. We're trying to minimize the amount of in-person follow-up for these patients, but if required, we have a protocol where outpatient labs can be done safely in the infectious disease clinic with full PPE. Next slide. And then with regard to home management, if a patient that is a transplant recipient calls with fever and or respiratory symptoms, a known COVID contact, or positive testing, we add them to the transplant watch list as well with our COVID positive discharges. One of our transplant nurses calls every day with a symptom check template. If they're getting worse, they're directed to call 911 or to come to the Northwestern ER with a proper handoff. Our census is usually around 35 patients each day. And as of Friday, when I made these slides, we had 11 total COVID positive patients admitted via the watch list. Most notably, all of them were initially admitted to the floor. The benefits of this is that these patients are getting early medical attention at Northwestern, where their transplant team knows them. They have access to clinical trial medications and our ICU team. And this more focused on our patient condition rather than the accessibility of outpatient testing access. So when we had reduced testing capability, our protocol really didn't change. Thank you.
Great. Thanks very much to all of our speakers. I just have a few little questions for each of you. Ali, I wonder if you could share with us your approach to the management of ACEs and ARB inhibitors in your patients, given the questions about receptors for the virus. Have you changed that?
Yeah, so far our practice has been to not hold those drugs if the patients came to the hospital on one of those drugs, unless there's another compelling reason to stop. So, if they develop severe AKI or have hyperkalemia or something like that, but otherwise we've not been making any changes. And I think there's been a positive evidence showing that doing so would cause any benefit.
Great, thank you. Marta, you brought up the issue of embolic complications, specifically pulmonary emboli, and that's something we've been worried about too. What is your approach to anticoagulation for these ICU patients?
Yes, we've been discussing that a lot in our center. So basically, they are on prophylactic anticoagulation anytime they go into the ICU. We increase the doses to milligram per kilo if they have a D-dimer that's over 3,000. And if something's wrong with their oxygenation, we go for CT scan. We try to restrict CT scans at first because it was so cumbersome to move them to the radiology department and so on. But in the first 50 scans that we performed, just following the simple rules, just D-dimer over 3,000 and oxygenation issues beyond expected, we, in the first 50, as I'm telling you, we found 25 patients with a emboli. So we are trying to, as I say, increase anticoagulation to milligram per kilo if something looks too inflammatory or the D-dimer is high, and go straight for CT scan if there's any minimal doubt.
Great, thank you. Enrico, you spoke about some of the cardiac injury issues being related to cytokines. I'm wondering if you've tried cytokine blockade in any aspects for your patients in whom you're concerned about this.
We have a recent experience, for instance, with transplanted patient, but in that case, a cardiac transplanted patient, and in that case, there was no, decrease of the ejection fraction. But for instance, in a patient on cyclosporine plus mycophenolate plus low dosage of prednisone, that patient developed a significant inflammatory response with C-reactive protein of 105 with the upper reference limit of 0.5. So interleukin-6 was 86. So we treated this patient with the tocilizumab when he was dependent on CPAP, and we had a significant improvement in 2 days. So it's almost our standard of treatment, in particular in patients without any infective superimposed infection with a high level of interleukin-6. While for patients with myocarditis, for instance, the patient we described in JAMA Cardiology from Brescia, we treated this patient with the corticosteroids, intravenous corticosteroids, and the dosage was 1 to 2 milligram per kilogram intravenously for 3 to 5 days. And there is also another paper in the European Heart Journal in a patient with cardiogenic shock that he was treated with steroids with a significant improvement. So I believe that even if we do not have a simple reply, that could be applied for patients with myocarditis, at least based on this just personal experience.
Great, thank you. Simon, you brought up the issue of just you bringing up research from the past week, and I think one of the things we're all dealing with is how rapidly this is changing. How do you determine what you're going to use for treatment protocols for your patients when the field is changing so quickly?
So I think that's a really good point. Part of it is I think all of us are getting data exhaustion from multiple trials and case series. So some of the data that I highlighted, I think, they're not convincing, and especially I think for hydroxychloroquine, there's a chance of greater harm than good, in my opinion. So we are lucky in that we have a number of clinical trials at our institution. So our goal really is for these patients to be, enrolled in these clinical trials and get treatment in that way. The tocilizumab in particular, I'm interested and I'd like to use it. I think there probably is a subset of patients that we need to identify that will perhaps be better served by receiving it versus in general. And for mild disease, I had a patient last week. We're not treating with anything at all, just doing daily phone checks with the patient.
Great, thank you. And Sejal, one of the questions that I wonder about is when we have transplant patients we're trying to keep at home, what do we tell them about their household contacts? Is there special advice you give to them regarding household contact, or nothing additional?
Yeah, so some of the main things is that we try to have them self-isolate in their own bedroom and try to have their own private bathroom. And this is also something that's coming into play for safe discharges. If people are sharing those common spaces, then we try to get them a hotel or work with social work for alternative housing.
Great, thank you. Thanks all for wonderful presentations. And now I'm going to turn this over to Dr. Lloyd Ratner.
Thank you, Emily. So now we'll talk about a little bit about to wrap this up, the ethical issues and utilization of resources. Next slide, please. We have three ethical experts. We have Dr. Angie Wall and Dr. Juliana Testa, both of whom are abdominal organ transplant surgeons at Baylor University in Dallas. And from above the diaphragm, we have Dr. Andrew Courtwright, who's a transplant pulmonologist and a medical ethicist at the University of Pennsylvania. So next slide, please. So why don't we go ahead?
All right, this is Angie Wall. I'm going to start it off. Thank you, everyone, for joining us today for this discussion. We're going to talk about the ethical challenges of managing resources in transplantation and COVID-19. So as everybody's aware, we are used to dealing with scarcity in organ transplantation and donor organs in particular. And across the world, we've developed consistent, transparent, organ-specific allocation schemes that prioritize recipients who match with each donor based on factors such as waiting time or severity of disease. While these allocation schemes are still in place, many centers have had to shift their approaches to transplantation based on this absolute scarcity of all sorts of resources, such as ICU and hospital beds, ventilators, medications, and PPE. So we do have a practical problem, which is who can we transplant given the limitations and resources that we're facing? But we also have an ethical question, and that is who should we transplant based on these limitations? Next slide, please. So what we can do is we can start by using the principles that we always use for allocation. The first being distributive justice. So what that does is it gives us principles on how to prioritize patients for transplantation. What is going to happen with distributive justice is that it's a moving target based on where we are in the COVID incidence curve. So for example, if I currently have the resources for transplantation, but I'm expecting a decrease in resources, the underlying principle for who should get transplanted might be to focus on maximum benefits with minimum resource use. So something like a straightforward kidney transplant. Whereas when resources become even more severely restrained, the focus is going to shift more to a sickest first allocation, such as status 1A hearts or fulminant liver failure patients. Now, there are other ethical principles that we have to think about. One is balancing risks and benefits. As we've heard in this talk already, there are risks associated with COVID infection in transplant patients that we're getting data on every day, and it's changing. And so this is a consideration as for hospitals that are in areas, especially with community spread and the risks of nosocomial infection, those may outweigh the benefit of transplantation in certain patients. Another ethical principle is that of respect for autonomy. So as we have to do in other situations, we have to keep our patients informed. And we have to keep them informed about both the knowns and the unknowns of the current situation, of the potential for the unknown course of COVID infections in post-transplant patients with the real risk of morbidity and mortality, as well as the false negative rates of donor testing and the potential for donor-derived infections that we have not yet seen, but we might see. Finally, and perhaps the most important point, is that we really do need to maintain clarity, transparency, and consistency in the way that we make our programmatic decisions about who we're going to transplant, so that we can maintain trust in organ transplantation and in our programs. And we'll move on to the next slide, and Dr. Courtwright is going to talk about that one.
Thank you. So when we do reach a situation where we've transitioned from usual standards of care to crisis standards of care, it's been well acknowledged that the ethical guidelines and allocation principles shift away from our common principles in transplants, such as rescuing the sickest, to allocation where the primary goal is to maximize the number of lives saved, with additional considerations for the number of life years or life cycle years preserved, along with some considerations regarding healthcare providers and other essential workers. Regardless of the allocation framework, but particularly in crisis standards of care, these allocation decisions should treat all patients equally. And that includes both COVID and non-COVID, including transplant patients, where what we're trying to assess is what is the benefit to this particular patient for this particular resource, given his or her comorbidities, current clinical status, and combination of severe or major life-limiting comorbidities. In all of these cases, they're extremely complex assessments, and they should be made in close coordination with triage teams or triage officers, and should include an honest assessment of the likely duration of post-transplant recovery and the need for local institutional resources, as well as the risk for clinical deterioration following index hospitalization. But overall, it's extremely important to remember that we're embedding transplant within this framework, and not that this is a framework that is solely designed to direct resources towards COVID-19 patients. Thank you.
Great. Thank you, Angie and Andrew. Let me, in the few remaining minutes that we have here, let me ask you a couple of questions. Angie, you talked about the unknowns, and certainly we're really in uncharted waters here with very little available data, particularly about long-term risks and effects. So what we really have is a catch-22 here, because if we wind up taking the conservative approach in terms of suspending transplantation or largely curtailing transplantation, we're not going to be able to get the data. So how do we square this, or how do we address this from an ethical standpoint?
So one thing, and this is really what one of the things that Andrew brought up, is that we do have knowns. We know that a patient in fulminant hepatic failure, for example, is going to die if they don't get a transplant. What we don't know is how they'll do if they also somehow get a COVID infection afterward. And so we can't just say that we have to send all of our resources toward COVID-19 and not take care of these other patients that have significant risk of mortality. And so I don't think that curtailing all transplantation makes sense in the setting of the greater medical system, just like not treating heart attacks doesn't make any sense. So I do think that we have to take into account the fact that our patients do face significant morbidity and risk of mortality. And if we stop transplants, then I think we are doing a disservice to transplantation and to our patients in general.
But how conservative should we really be if we're not getting, because it may be that it may be reasonably safe to transplant some patients who aren't that sick.
Yeah, this is Giuliano Testa, but that's important in view of the data that we saw in the first slide from Yunus, whereby, interestingly enough, we saw an interesting drop, significant drop in the number of kidney transplant patients that, if you think about, are also the ones among older transplant, being this thoracic or abdominal, absorb less resources. And if you look at this in terms of the greater good and taking care of as many patients you want, whether those are transplant patients or not, you may want to think that would be a good ethical approach really to start discussing whether you can really save a lot of lives by doing the transplant that absorbs less resources in general. So that is a conversation that, honestly, should be carried on now that the shock is being absorbed as we speak, and we go into the next phase, which is the phase after the shock of the pandemic.
Well, so that brings up a good point, Julie, director of a transplant center. And as we start coming out of this, there's going to be a backlog of cases for that from virtually every discipline. That's going to be, everyone's going to want to demand their resources. So, in transplant, we've sort of gotten used to the idea, because of the whole issue with the metrics, in terms of deciding what's right for our institution versus what's right for our patients. How are you going to make the argument to get the most resources that we could get for our transplant patients as we start coming out of this? OR time, hospital beds, etc.
This is a very important point. Our institution already told us that we're going to have a significant restriction in financial support for all service lines, including transplant. So I think that will really start a nationwide conversation on how to work better together in terms of decreasing, for example, the cost of, I make an example, the traveling or procurement. At the end of the day, if you see this from a cumulative point of view, in an entire basket, you can really do a lot within your institution, and we can do a lot within centers in helping each other, because it's going to be affecting all of us.
Okay. And down to making sure that you're dealing with these questions at a centralized level within the institution in a way that is both fair and consistent for non-transplant and transplant patients, where you're really thinking about medical need, you're reflecting on kind of a return to the usual standard of care guiding ethical principles, and not just saying, what can we do right now to maximize resources once you're out of that phase of care.
Okay. And let me ask one other question that's sort of related to another aspect of transplantation that we haven't talked about much during this whole crisis. But, living donor transplants, we could defer. The donors hopefully will still be around when we get back to transplanting at full speed. But deceased donors, they're a one-shot deal, right? And if those organs are declined, or not utilized for one reason or another, then we result in the loss of a scarce resource or a scarce opportunity. So what ethical obligation do we owe the potential recipients, and more importantly, the donor families, to try and optimally utilize these organs?
So I'll start with that one. There's a great article by Ezekiel Emanuel written in the New England Journal about ethical considerations in scarce resource situations in COVID-19. And one of the things that he brings up is this idea of instrumental value of, and what he talks about is the healthcare workers, and so they should get some sort of priority for treatment because of their instrumental value of giving back to the treatment of COVID patients. But what I think about with instrumental value is the instrumental value of a deceased donor. That deceased donor has the potential of saving multiple lives. And so when you think about the utilization of resources for a deceased donor, what you can get out of that utilization is saving the lives of several patients who would die otherwise. And so when we are in triage situations, especially deceased donors who have the likelihood of donating multiple organs, should really be considered as a priority, I think, even still. And we can see that because even the presentations we saw at the start, we're not stopping all deceased donation. Everyone is trying to continue with some level of deceased donation because, as you noted, Lloyd, this is a very limited resource. One thing I would bring as a caveat is we should be thoughtful about the amount of time that we take for working up donors and accepting offers, so that we decrease the drain on resources from that. If you don't need a test or you can do it in the operating room, then don't request things that are going to delay the operating room time. if we use local recovery, we don't have to factor in travel time, so that can decrease the amount of time that you're utilizing resources as well.
Great. So Andrew, Angie, and Giuliano, thank you very much for this thoughtful discussion. This is about wrapping us up. We have a couple of other housekeeping issues. I'd like to thank all the other organizers of this and all the societies that have contributed. I'd like to thank all the participants who spent their time and data and shared that. We have two little polls I'll ask you to answer for all anyone who's been listening to this webinar. And the first is, and you can just click on your screen, I found this webinar to be helpful in expanding my understanding of COVID-19 and its impact. You could select one of the following: strongly agree, agreed, neither agree nor disagree, disagree, or strongly disagree. So everyone please click on that. And then the second question is, I would be interested in participating in or viewing future updates to this webinar. And then the same graded responses. Again, this webinar will be available online in relatively short order. There will also be some additional pre-recorded modules that will recover precautions for the procurement team, screening donors and candidates, protecting the workforce in terms of surgical aspects, and protecting the workforce in terms of infection control. It seems like there were live about 600 viewers who started with this webinar, and we still have over 400 left at the end of it. So thank you all for staying on, and be on the lookout for additional webinars. And we're even considering for the additional webinars being able to grant CME or maintenance of certification for a nominal fee. So stay safe, and look forward for you joining us in the future webinars.